So as usual, we can divide the clinical feature as local feature. Clinical feature due to the presence of bladder cancer inside the bladder. Feature of locally advanced cancer, and feature of metastatic cancer. Hematuria is the most common and the earliest feature of bladder cancer. And the hematuria has a typical characteristics. Okay, it is gross. Gross means the patient can see it. Okay, gross, but it may be microscopic. Okay, and it is painless. Don't forget, painless. And total. Total means the entire urine is red, and it is intermittent. Painless, total, intermittent, gross hematuria. This is the characteristic feature of hematuria due to bladder cancer. And the second feature is irritative LUTS. Okay, or you can say storage LUTS symptoms, same thing. So what does it mean? See, this is bladder. Okay. And you know, this is opening of ureter. Okay, this is the bladder neck. A triangular area between these ureteric orifice and the bladder neck is known as trigone. And if the if the bladder cancer is just near this trigone, or if there is a carcinoma in situ, flat tumors, these two situations, it irritates the bladder a lot. Once it irritates the bladder a lot, it produces features like frequency, urgency, nocturia, and dysuria. What about locally advanced? Locally advanced means it depends on the involvement of surrounding structure. As you know, in female, it may invade the vagina or cervix laterally or behind. In male, it may invade the prostate or rectum, and in both male and female, it can involve the pelvic wall. So when you do a DRE in male or vaginal examination in female, so what we do is we put one hand, left hand in the abdomen, and the right finger, two finger into the vagina, or one finger into the rectum, and try to feel the organ in between our palm, left palm, and right finger. We try to feel it, and if we are able to freely move these organs, then we can guess, okay, the cancer might not have involved the surrounding structures. But if it is fixed one, or if you can feel something in your finger, hard mass, then it indicates the cancer has local advancement. This clinical examination is usually done under anesthesia, because whenever we want to examine by manually, it is a bit discomfort. The patient will feel some discomfort. That's why we do that under anesthesia. Regarding the metastatic feature, so metastatic feature, you know, metastatic feature depends on the site of metastasis. If the cancer involve the lung, then you know the feature will be chronic cough and hemoptysis. If the cancer involve the liver, then extensive involvement may cause hepatomegaly or jaundice. If the cancer involve bone, patient will have chronic bone pain, back pain, or fracture of the bone. In brain, then patient may have a chronic headache, convulsion, or vomiting. Okay, so depending on the organ involved. What about the lymph node? If the pelvic lymph node is involved, then there could be a lymphedema. Okay, left supraclavicular lymph node is involved, then we say it's a systemic disease. Whenever there is a metastasis to any organ, there are some general features of metastasis: anemia, asthenia, anorexia, and weight loss. Okay, these are the general feature of metastasis. Investigation for diagnosis. So what are the investigations that we do for diagnosis? Let's see. Urine cytology and urine bladder tumor marker. What is that? See, so this is the epithelium. So this is the bladder cancer. As you know, these epithelium, they set down. It just fall down. Shedding of the cancer cells occurs, and it get mixed with the urine. Okay, urine. And if you collect this urine, and do cytology, then see, in high grade cancers, you may be able to find positive cytology. The cytology is positive, that means the patient might have cancer in urothelium. Urothelium means it could be arising from bladder, it could be arising from ureter or pelvis, from anywhere. Then in low grade cancers, I'll tell you what is low and high grade. In low grade cancers, these are not found positive because they don't shed that much of these cells. In high grade cancers, you'll find the cytology positive. So that means if you're suspecting a patient is having a bladder cancer and is negative, that doesn't mean the patient don't have a cancer. But if cytology is positive, then it is definitely sure the patient has a cancer. If it is negative, it doesn't mean patient don't have a cancer. Positive, it always mean patient have a cancer. We also check for tumor markers, especially tumor markers are the chemicals released by tumors. In the case of bladder cancers, we check tumor marker in urine, not in blood. In urine, we check that. Okay, bladder tumor antigen in nuclear matrix protein 22. The good thing about ultrasonogram, it can show you tumor. It can show the number of tumor. Whenever there's a tumor, there may be a single large tumor, or there will be small multiple tumors. You can find that. Okay, and in addition to that, what you get, we can get an idea about the condition of kidneys. Okay, condition of kidney. If a tumor, listen to me, if a tumor is very near to this orifice, then they can block the orifice. See, they can involve the ureteric orifice. We say VUJ is involved, vesico ureteric junction. Once the VUJ is involved, what does it do? It causes hydroureteronephrosis. See, so see, if a patient of a bladder tumor present to you with hydronephrosis or hydroureteronephrosis, obviously hydroureteronephrosis, then think the bladder tumor has involved the VUJ. Why it is important? Because once it has involved the VUJ, this patient has already a muscle invasive cancer. What bladder has 3 layers, right? So this is if the cancer has arise from the epithelial surface, and then it can go deeper to involve the muscle. This is muscle. To block the VUJ, it must involve the muscle of VUJ. If the muscular area of VUJ is not involved, then there will not be hydronephrosis. So see, the treatment is entirely different in muscle invasive and non-muscle invasive cancers. Okay? So it will give us idea about the tumor, idea about the numbers of tumor, and also give idea about the condition of kidney. It's very good. Then what is bad about it? Smaller tumors or carcinoma in situs, they are missed. Can you do CT scan? Yes, why not? Contrast enhanced CT scan, abdomen and pelvis. Abdomen and pelvis. Yes, this is very, very good in the sense that it can even identify very small tumors. So it's very good. It gives us all the information of ultrasonogram, you get it. Plus, it can show you the smaller tumors. Plus, it can give you idea about the local invasion, like a bladder cancer has involved the local organs, there's liver involvement, bone involvement, lumbar vertebrae involvement of the rectum, vagina, uterus. All those things can be seen easily by CT scan. See, some surgeons prefer to do it after cystoscopy and biopsy. Some surgeons prefer to do it before. Doesn't matter. You can do before, you can do after. Doesn't matter. What is the most important diagnostic investigation that we do? The diagnostic is cystoscopy plus biopsy. We introduce our telescope into the urethra, go to the bladder, see the bladder, and after seeing the bladder, you take a biopsy from the tumor and then confirm the status of the cancer. That we don't puncture the abdomen and take a biopsy. We never do that, because urothelial cancers are very, very aggressive cancers. If you puncture an abdomen and take a biopsy, then it can cause a seedling of the tumor. This is the best investigation, is cystoscopy and biopsy. Okay. Metastatic evaluation is same for any cancers. You guys know that. We always do X-ray chest or CT scan chest, because chest is the very common site of metastasis. Liver function test is always done to assess the liver condition. Alkaline phosphatase is always done to assess the bone metastasis. And if the alkaline phosphatase is high, if there is a symptoms of bone pain, then you can do bone scan and other investigation depending on symptoms, like if there is a headache, vomiting, nausea, then you can go for brain MRI. So these investigations are exactly the same that you have learned in RCC or Wilms tumor. Similar. Urine cytology. If a patient has negative cytology, urine cytology negative, that does not mean he don't have a cancer. But if the patient has a positive cytology, then yes, he is having cancer, no doubt. Okay? So it has some importance in that way. Urinary markers, that is tumor markers. we see the urine. Okay. So NMP22 and BTA are the tumor markers that can be checked in urine, not in blood, urine. Okay. So ultrasonogram will give us idea about the number, the location, the size of tumors, even a condition of kidney and ureter, that is hydronephrosis or not. Okay. The disadvantage is it will miss the small tumors and carcinoma in situ flat tumors. Okay. See this bladder. So this is the outline of this is the bladder. This is the mucosa of bladder. You can see the mucosa of bladder, the mucosal layer, and you can see a mixed density mass, a mixed echogenic mass is arising from the lateral wall of bladder. You see the big, you can even measure the size. Size has importance. Okay, you can measure the size. A mass is arising from the wall of bladder. Single mass. See this the image. Here you can see two smaller masses arising. See. Now, CT scan. It can show you the tumor. It can show you the numbers, size, everything. Plus, it can give you idea about the local involvement of surrounding organs. It can also give you idea about the involvement of the distant organ like liver or bones, the lumbar vertebrae. Okay, see, it's very accurate than ultrasonogram, no doubt. See, the tumors can be seen, local extension, lymph node status, everything can be assessed. Sometimes if the patient has a contraindication of MRI, CT scan, then you can do MRI. But most we do CT scan. Okay, see how does it look. This is the non-contrast CT scan. What you can see over here is this is the bladder. Okay, and you can see a big, broad, mixed density mass is arising from the bladder floor. See. Now this is the contrast, contrast enhanced. How I can say contrast? See, still there is a gray. that it is not filled completely, but you can see the bladder is partially filled by the contrast. And here you can see something is projecting into the bladder, and even it is outside the bladder. See the condition here. Compare these two images. Here the tumor is still inside the bladder, but here the tumor has come out of the bladder. So it is already a case of locally advanced tumor. So you can see that, and see, obviously it is a mixed density mass with a filling defect. This much area is not filled by the contrast. That's why we say filling defect. Okay, so see, you can see the tumor like this one. Let us see the CT scan in a in a coronal view. These are the axial views. This is coronal view. Okay, you can see over here. This is the bladder. It is a contrast enhanced bladder. You can see it is filled with contrast, but this area is having filling defect. And the coronal image can give you a lot of ideas. See, even I can see the liver. See the liver? The liver is very good because whenever there is a metastasis to liver, some hypodense black spots, okay, in metastasis. But here we are not seeing any metastasis. So just in this case, I can say there is no liver metastasis, right? But there's a bladder tumor. I can see it. Now, as I've already told you, the cystoscopy and biopsy is the most diagnostic investigation that we do. What is cysto? Cysto means bladder. Scopy means to see. So what we do is we take a cystoscope or telescope. We introduce through urethra, go inside and see the entire bladder and check for the tumor. And if you find tumor, then we just take a biopsy and send for the histopathology. That the lab will confirm you about the disease. So the picture that you are seeing in the right lower corner, so you see sometimes the tumor is maybe very big like this one, big tumor is there, sometimes very small tumor. Okay, so you have to take a biopsy from this area. We normally use white light, white light. You can see this is the white light. See, the white light means normal light. So we normally use white light to see the tumor. But the carcinoma in situ is so notorious, they are so flat, it is very difficult to identify by white light cystoscopy. In that case, we use a blue light cystoscopy. What is that? I'll tell you. Wait. Most routinely, we do white light cystoscopy and check it and do the biopsy. But if we are confused that a patient might have a carcinoma in situ, flat tumors, then we have to take the help of blue light cystoscopy. What is that? I'll tell you. Wait. Yeah, this is the cystoscope. You can see the long sheath, and inside there is a telescope. After doing a spinal anesthesia, we use a cystoscope and we use a lot of lubricant. And then we pass the cystoscope slowly inside the urethra. See, this the urethra is visualized now. So we are going slowly. Okay, the normal saline is used to go through and see. This is the verumontanum of veru. Now this is the prostatic urethra. Yeah, this is the prostate, you can see, and the posterior part is the urethra. Lateral is this prostate bulging. Yeah, this is the bladder neck. We are now entering into the bladder neck. Now we're inside the bladder. So this is what cystoscopy means. Now we have to search for the tumor. See, the tumor is visualized already. We're first searching the ureteric orifice, opening of the ureter. Okay. See the tumor. There's a big tumor inside the bladder near the right ureteric orifice. Okay. Once you see the tumor, what we do is we search other area also, because we have to confirm about the characteristic of tumor. Right here, we are seeing the tumor size. We are seeing the number of tumors, and moreover, we have to see whether it's a flat, sessile, very broad base, or like stalk, having a stalk. Okay. Now we are assessing the mobility of stalk. The instrument that you are seeing over here is the resectoscope. Okay, now see, we are resecting the tumor by using a current loop resectoscope. Okay, so first we resect it from the bladder. Sect. This is known as TURBT, transurethral resection of bladder tumor. TURBT. So resecting the bladder tumor is actually we are doing the biopsy. Okay, this is known as resection biopsy. And when we resect, obviously it bleed, so we can coagulate, burn it during the process, such that it prevents the excessive bleeding. Resecting and coagulating the bleeding point. Okay. Now, telescope is removed, and now we'll collect that resected bladder tumor. See, we can see the resected bladder tumor. This is a resection from the tumor. Now we have to take a base. What is that? Wait, I'll tell you. So now see, this area, this is the area of the bladder tumor. We have already removed the bladder tumor. But for the proper diagnosis, you have to take the base of bladder tumor. Base means you have to resect the base such that you will take a muscle biopsy as well. Okay, the muscle has to be taken. See, now we are cutting the muscular part of the bladder just at the base of tumor. See, yeah, now we are removing the base of tumor because we have to identify whether it is a muscle invasive or not. We are taking the muscle biopsy now. Now almost it is done. Now we will coagulate the bleeding point. Now the specimen should be removed and collected separately. That means previously we got the tumor part, the body part of tumor. Now we got the base of tumor. These two things has to be separately sent to the pathology. Don't mix it, okay? Because we want to know whether the cancer has involved the muscle or not, which is only possible if you send it separately. We are burning the margin so that they will not be bleeding. Okay. And now we put a catheter, and see this catheter. Always, whenever you do any treatment of a bladder or a prostate, we always use a tri-channel catheter. Tri-channel catheter. Why? Because later on it may bleed. So to prevent that clotting inside the bladder and you know, for irrigation purpose, we use tri-channel catheter. At least 20 friends, 22 friends. Okay. So this is what cystoscopy and TURBT. That is, we have seen the bladder tumor first, assess the tumor, number of tumor, the mobility of tumor. Then we have resected the tumor for biopsy purpose. You can see we have resected from two different places. One from the body, totally removed, and then after removing the entire tumor, then again we enter inside and took a biopsy from the base of tumor. That is very, very, very essential process, because that will give us idea whether the muscle has involved or not. Okay, very much important. Anyone tell me, is there any abnormality in this picture? It's very normal looking, right? See, this is a white light cystoscopy. The process that you have seen, the TURBT, was done in normal light. Okay, so sometime the white light cystoscopy will miss carcinoma in situ. The carcinoma in situ look velvety, red in color, but normally it is missed. Okay. Now, can you see any abnormality now? Same patient, same image. Yes. What you can see over here is this one, which is supposed to be here. So this is the beauty of blue light cystoscopy or ultraviolet cystoscopy. when we suspect a patient might have carcinoma in situ, okay, we do it routinely. Now, just changing the light, can it just show you the abnormality? No. For blue light cystoscopy, we have to add some drug. Okay, what is that? This is also known as photodynamic cystoscopy or fluorescence cystoscopy. We add the fluorescence dye. What is that? That is amino levulinic acid or hexaamino levulinic acid. What we do is we first fill the bladder with that dye, that chemical, and wait for a while, and then we use a blue filter, that is ultraviolet filter, to change the color of the light. Then you can see flat tumors. So flat tumors, that is carcinoma in situ, which cannot be seen normally by the yellow light, can be seen by the blue light cystoscopy. A bladder tumor may be flat like this one. See, a bladder cancer, a flat tumor is very difficult to see. Yes, it has some character, like it is a red velvety color, but red velvety color, you may miss it because normal mucosa of the bladder is also pinkish red in color. So the chance of missing the carcinoma in situ is very, very high. That's why to visualize this cancer, we use the chemical first, and then we use blue light, such that this tumor will glow red in blue light, such that you can see the tumor area, and then you can take a biopsy from that area and confirm the carcinoma in situ. Okay. Now, let me summarize about cystoscopy and biopsy. Mucosa. Suppose this is bladder tumor. Okay. So once you introduce the cystoscope or telescope inside the bladder, then you can get a lot of information. You can assess average size. Average size can be assessed. Okay. Mobility, that is, it is mobile or free. Like these all are tumor characteristics. Tumor character. This is that you can get from cystoscopy. Okay, cystoscopy. And then what you get from biopsy is, number one, confirm your diagnosis. This is bladder cancer. They will tell that. And not only that, they will tell you whether it is TCC, squamous cell, or adeno. Another very, very, very important thing is whether it is muscle invasive or not. How can we say that? I've always shown you in the video that we take the biopsy separately from the base of the tumor for muscle invasiveness. And the most important thing is whether it's a muscle invasive or not. Whenever you see the report of biopsy, always try to see these informations, very essential for management. And obviously, by using the blue light, you can also see the carcinoma in situ. Yeah, one more thing, grading. Low grade, high grade. They can say it by seeing the histology. This is the high grade tumor or low grade tumors. Usually muscle invasive cancers and the carcinoma in situ, they are usually high grade. They are aggressive. Okay. So see, you have seen how we have taken the biopsy. We have taken the biopsy in this video by resection. That is, we did TURBT, that is transurethral, through the urethra, resection of bladder tumor. So if the report comes out, it is non-muscle invasive, then we don't do further surgery. We add some chemotherapy, but we don't do further surgery. So sometimes it acts as a treatment for non-muscle invasive bladder cancer. Okay, fine. Now, metastatic evaluation, you already know what we do. always do CT scan, chest or X-ray chest to evaluate the lung metastasis. Do it routinely. You see a multiple white opacities in lung. Liver function test, do it always routinely. CT scan abdomen, we always do that because we want to see the tumor involvement into the surrounding structures, or tumor involving the liver, or tumor involving the bone, or tumor involving the lymph node, that can be seen by CT scan abdomen. Alkaline phosphatase, do it routinely, because increased alkaline phosphatase in the case of bladder cancer will give you idea there could be metastasis to bone. Then to confirm, we will add bone scan. Bone scan if there is symptoms. Brain scan, brain MRI if there is symptoms. Otherwise, we don't do it routinely. Okay. Bladder having a huge bladder tumor here. Okay. And the same patient is having hypodense mass in the liver. So this is the liver metastasis. In kidney, you can see that this is a cyst. This is a cortical cyst. Okay. Cortical cyst. So you can see a hypodense mass in the liver in a patient with the bladder cancer. This is the case of metastasis. You can see that. Okay. Carcinoma bladder with liver metastasis. Bones are good. Lumbar vertebra, okay. Yeah, it is curved, but there is no metastasis. Yeah, the most constant, persistent feature of bladder cancer is always hematuria. See, let me tell you one thing. Whenever you get a patient of a painless hematuria in the elderly patient, the first diagnosis should be always bladder cancer. This is the most common type of cancer in the urinary system. Yes, cancer prostate can cause bleeding. The BPH can cause bleeding. The bladder stone can cause bleeding. But bladder stone causes painful bleeding. So this one. What is the key point over here? Heavy smoker. Then you have to go back to your again basics. Which tumor is very common in smoking? Those who smokes, the most common variety is transitional cell carcinoma, not the adeno or squamous. See, the answer is C. Again, don't we do ultrasonogram KUB? Yeah, we can do both, right? So both is correct. What are the investigations that we do for bladder cancer evaluation in this four option? In this four option, we do cytology and we do ultrasonogram both. Best one is always cystoscopy and biopsy, the diagnostic one, right? Urothelial carcinoma means cancer arising from urothelium. Means it could be bladder cancer, it could be urinary cancer, it could be pelvis cancer, or even urethral cancer. So whenever the cancer arises from any of these area or urothelium, then it is regarded as urothelial cancer. The most common urothelial cancer is bladder cancer. Okay, so the cytology, urinary cytology, is done for urothelial cancer. You can say bladder cancer. Okay. So the tumor marker for bladder cancer are NMP22 and BTA, bladder tumor antigen. So here you got answer NMP22.